is Paulette Lewis. Paulette is a nurse practitioner working at the Scarborough Health Network in the Regional Nephrology Program. She works full-time in the Multicare Kidney Clinic. Paulette graduated from DeVille College with a Master of Science in Nursing in 2004. She completed her nurse practitioner's course at the University of Toronto in 2007. Paulette's caseload entails working with patients with stage 5 chronic kidney disease. Her role focuses on patient self-management, including preparing patients to make decisions regarding dialysis modality options. Paulette is also the independent dialysis coordinator for the Ontario Renal Network. Ladies and gentlemen, please help me welcome Paulette Lewis.
There we go.
There you go.
Okay, can you see my screen okay?
Yes, we can see the screen. That's
okay, so I want to say thank you for that nice introduction. And I want to thank the Walnut Foundation for inviting me to speak today. Now, I know I sound a little bit like Barry White. I'm sorry about that. I'm overcoming laryngitis, so I'll do my best to get through this. If you don't hear me for a bit, it's probably because I'm taking a sip to try and get my voice going. I want to thank Dr. Nathu because he's pretty much done my whole presentation for me. So it'll pretty much be a review from what he said.
Okay.
Okay, so how do I advance this? Okay, so my objectives were to differentiate between acute and chronic kidney disease and to help gain an understanding of the 5 stages of kidney disease and understand treatment approaches or options for people living with chronic kidney disease. So Dr. Nathu has already gone through the difference between acute renal failure. He said it's something that's suddenly onset and a potentially reversible. Something like getting a blockage in the kidney or in the prostate, having a kidney stone. It can, however, if not clear, lead to kidney disease or chronic kidney disease. Chronic kidney failure progression is usually lasting about 3 months or more, and it's usually permanent, irreversible. And we often know the cause. It could be from diabetes, as he stated, high blood pressure, inflammatory conditions such as nephritis in the kidney. It could be hereditary, such as polycystic kidney disease. And he already alluded that diabetes and high blood pressure are the 2 leading causes of kidney disease. Now, his picture looked a little bit different. This one is just outlining the 5 stages of kidney failure, which is where my presentation is going to be focusing on. So stages 1 and 2, we wouldn't really see much. They're managed in the doctor's office. They may see a nephrologist as well. Stage 3 is about 30 to 60%. Stage 4 and 5 are the ones that I would be involved with, where the kidneys are working at 15 to 30%. Or those that are at end stage, which is my caseload, where they're less than 15%, they're requiring dialysis or a new kidney at some point. So I always like to get you to understand by doing a case study. So I'm going to introduce you to Dave. Now, Dave is a 55-year-old Black male. He's married with 2 children. He is the owner of a mechanic shop. And he works full-time. He has a history of high blood pressure and diabetes for approximately 15 years. Now, Dave is in stage 3 kidney failure. His creatinine is around 175, and Dr. Nathu talked about creatinine. It's really the waste that we measure in the kidney, and the normal is 60 to 110. His kidneys are functioning at about 32%. Normally, when we talk about percentage, we're talking about 100, so it should be normal at 100. His hemoglobin, which is what gives him his energy to do his work and so forth, is pretty okay. It's a little bit low, but it's 131. Normally, it's 135 to 175. Potassium, calcium, phosphorus. These are minerals which keeps our body healthy. Those are all within normal range. His blood pressure, however, is not good. It's 160/90. We want to keep our normal blood pressure is 120/80. And his sugar is also not very good. And I showed you the normal on the side. Now, regardless of what stage your kidneys are working at, as Dr. Nathu alluded, what we want to do is lifestyle management or lifestyle changes. And the first thing is maintaining a healthy, balanced diet. Normally, I tell my patients that the diet really is the cornerstone to their kidneys working very well and for keeping them healthy. So in Dave's case here, he has high blood pressure. So although he has, we know he has high blood pressure, we want to keep the blood pressure reading below 140/90. His is 160, so that's still very high. And because he has high blood pressure, so he has diabetes along with high blood pressure and kidney issue, we want to even tighter control. And the normal for someone with diabetes should be about 130/80. Blood sugar, we want to keep it as normal as possible. So 3.5 to 7.8, somewhere in that range, to ward off other issues. And we want to maintain weight control, try to have him at an appropriate weight. And the dietitian who's speaking after me, I'm sure she'll talk about body mass index and why those are important to maintain a healthy body weight. Now, above and beyond what we've talked about, maintaining his blood pressure, blood sugar, physical activity is very important. So we want to have about 30 minutes of exercise daily. That amounts to about 150 minutes of exercise per week. It's going to help you to lose weight, maintain your blood pressure, maintain your blood sugar, your cholesterol, and overall, exercise is very good. Now, you don't have to be able to join a gym. Just going for a walk is a good exercise. Doing housework, anything that's going to keep you active and busy is going to help. Also, if you don't have 30 minutes per day at one time, like let's say, for example, you only get 30 minutes for lunch, you could do 15 minutes. 15 minutes in the morning and 15 minutes in the afternoon, or 10 minutes here and there. Doesn't matter, but we want to try and get 30 minutes in for the day. Smoke cessation, again, Dr. Nathu spoke about that. It increases your risk for cardiovascular diseases, including stroke or heart attack. And it's also associated with high risk of chronic kidney disease. Again, alcohol, you want to keep that to a minimum. There is a guideline as to how much drinks we can have in a day. And the dietitian, I'm sure, hopefully will discuss that. But alcohol really increases can have an impact on your blood pressure, your blood sugar, your cholesterol level, and your weight. Treatment with medication. So although there are no specific medication for chronic kidney disease, they are coming up with new medication that they find really help. They do kind of two jobs. They may help your blood sugar, but they're also known to help to keep your kidney under good control. But medication is prescribed to treat underlying causes. So preventing problems that may cause kidney disease or relieving symptoms caused by kidney disease. So for Dave, he would be on some form of blood pressure, diabetes medication. He might be on tablets, or he might be on insulin, or it might be in a combination of both. Blood pressure medication. Oftentimes our patients need multiple medication to keep their blood pressure under control or in an average reading. So I'll have patients say, but I'm already taking this for my blood pressure. Why do I need 5? Oftentimes you do need more than 1, or you may need up to 4 or 5 medications. And that's just because they're doing different things. Some are long acting, some are short acting, some are working on different part of the blood vessels. So not very often you see a person that's having just one medication. You may also be on medication that we call prophylactic. So you may be taking cholesterol medication. This is to help to prevent buildup of plaque in the kidneys or other arteries in your body. So you may not have lipidemia, you may not have high cholesterol, but you may be on prophylactic medication, because we know that people with kidney disease, and especially when they have a combination of high blood pressure and diabetes, they have a 25% greater chance of developing cardiovascular diseases, such as stroke, heart attack, or any heart abnormalities. Sometimes you might be given a blood thinner, some baby aspirin, for example, prophylactically to keep your, again, to prevent heart or complications. Just a word of caution about medications. So you want to take all your medications as prescribed. Inform your doctor or healthcare team before stopping any medication. I've seen it where sometimes patients are prescribed a medication and somehow they're under the impression that is just for 3 months. And so when the medication finish, they do not go to the doctor to get more medication. They just assume that they do not need it. So you always want to check with your healthcare provider. Oftentimes on your bottle, you'll see a refill. There's a refill on it, so you can go to the pharmacy and get more. Some medication may be prescribed, as I said, to help the kidney to work better or to prevent complications from developing. Your medication or dose can change. It's not, the doctor may have to adjust it accordingly. If your blood pressure is not coming down or your sugar is not coming down, the doctor may add medication or increase the dosage. Just want to put a little point in here about certain medication, which we call NSAID, or non-steroidal anti-inflammatory medications, such as aspirin, ibuprofen, Advil, and some pain medication. Dr. did speak about them, but they can cause your kidney to work harder and can cause damage. So you want to make sure that you take them accordingly and following the instruction on the medication bottle or your healthcare team instruction. I also want to add, please do not go home and stop your medications that are prescribed, because the nurse said there's a chance that it can cause other problem. Speak to your healthcare provider. Although aspirin is an NSAID, when it's given in low dose, it is quite safe. So please do not stop your medication on account of this presentation. Now let's look at Dave again. So now, a couple of years later, Dave, he's been following up with his doctor, but somehow he went back and his blood work showed that his creatinine is now over 300. His kidney function is down to 19%, so now he's in stage 4. Hemoglobin, which was what gave him energy to go to his work every day, is very low. His potassium is very high. Calcium and phosphorus, which are good for, which are known to keep your bones healthy, are very. I'm not sure why my slide is advancing ahead. Are very abnormal. His blood pressure is still high, and his blood pressure is high and his blood sugar is still suboptimal. He's also starting to have symptoms, swelling in his feet up to his ankle. He's reporting that he feels tired, he's eating less. And some of these are symptoms that patients can encounter as their kidney function deteriorates. Now, when you're being followed in a nephrology clinic or in a clinic that looks after your kidney or your doctor's office, as your kidney function looks as if it's declining, they will start to have a conversation with you about what can you do differently, or what, prepare you for what may happen. And usually this starts around 20–25%, not because you really need to do anything then, but just to get you prepared, looking at different options as to what we may have to do down the road. And so some of the things that would take place in with Dave's new reading is that because of his swelling, he may have to have a water pill added to his medication regimen, and also look at his diet again to further reduce his salt in order to prevent the fluid from building up, leading to other complications. Because he's tired and his hemoglobin is low, he would likely have to be started on iron if not already done, and also a special hormone replacing the hormone that the kidney is no longer able to facilitate with. He might be on vitamin D to prevent bone weakening. He may be on medication to help his potassium stay in the normal range, to help his phosphorus and calcium stay in the normal range. And there might be certain foods that he may have to avoid. So normally before a doctor prescribe medication for your potassium or for your phosphorus to keep those levels down, they would look at diet first. So they would send you to the dietitian to see what can be done to, what foods are contributing to allowing these levels to be suboptimal. Now we know that these minerals are available in every food, but there are certain foods that have more potassium, more phosphorus than others. And when we look at our diet, for example, and I know the dietitian will be speaking later, but when we look at our diet, there are certain things that Dave may have to cut back. So for those of us who like, our spinach or callaloo or ackee and saltfish, our plantain or bananas, green banana, ripe banana, oranges, tomatoes, those are food that are coconut water. These are food that are really high in potassium that oftentimes have to be limited when the kidney function are deteriorating and it's having problem excreting or getting rid of the waste that's building up. Same thing with certain, milk and dairy product, beer, for example, are high in phosphorus, and those may have to be limited. Now, sometimes our patients, and this is really interesting because I have patients who tell me that they're told to drink more by friends or family because they're trying to flush out the waste from the kidney. And that is not good information most times, because when you try to flush out, something can happen that can put the kidney to work harder. It just can't do it. It's only 19% working. And this could actually make it work worse by overburdening it. So sometimes we do have to limit something. So instead of having that large can of beer, he may have to have just a small one, or he may have to have less, a smaller bowl of soup if the swelling continues. Keep in mind that the restriction varies from one person to the other, and it's based on their blood tests and their kidney function and upon discussion with the healthcare team. So it's not a one size fit all that we're gonna change things for everyone, it's individual. So somewhere along there, as we're making these changes and modifying lifestyle changes and management through diets and medications, Dave would have been asked to see the nurse to start talking about a more long-term plan, given the fact that his kidney function has deteriorated and that he's having some symptoms. And Dr. Nathu again talked about them, and we're talking about the different options for treating your kidney. So we're talking about, I like to talk about kidney transplants first when I talk to my patients. And they're, this is where you get a kidney from a new person. From a person. Now, Dave, being not on dialysis yet, would not fit the criteria for getting a cadaveric kidney transplant or from someone who is brain dead or had an accident. So patients that I see in our kidney clinic, they have to get it, in order to get a transplant, they have to get it from a donor, from somebody who's offered to give them a kidney, whether it's a friend, family member, enemy, I don't really care. As long as they have somebody who's willing to give them, I'm happy to help them do the workup process. Sometimes they can get a kidney without, if Dave has a donor and we're able to do the workup, we can get him transplanted. We call it a preemptive transplant, meaning that he hasn't been on dialysis yet. So he goes from needing a kidney to receiving a kidney, and he's actually skipped dialysis. Dr. Nathu spoke about paired exchange, and this is where you have two sets of donors and recipient, but their blood type don't match. And so I want to give a kidney to my sister. Percy wants to give a kidney to Eugene, but they don't match. So my kidney goes to Eugene and Percy's kidney goes to my sister. So they kind of do a swap of kidney. And that's one way to do, to grow or transplant. There's also kidney pancreas, which is given to type 1 diabetes. And this is where a person, normally from a cadaveric or a person who has passed on, it's only type 1 patients that have type 1 diabetes that will qualify for this type of kidney transplant. But the good thing is that they're getting a new kidney and they're getting a new pancreas. So they're getting rid of their diabetes, as well as they're having a new kidney as well. I must say that they're intense, kidney transplant work involve intense testing and for both the donor and the recipient, because the doctor or the transplant office, there's only 2 here in the GTA, that's St. Mike's and UHN, Toronto General. So all the other hospitals send patients to these 2 sites to be transplanted, but they will not put a donor, at risk. So the donor is going to go through the same testing that the recipient would go through to make sure that they are healthy. And if they find anything that's abnormal, like say, for example, that person's blood pressure is high or their blood sugar is high or anything that may be questionable, they would do further investigation, or they may even abort the transplant because they do not want to put that person at risk. Transplant work can take up to a year to do, depending on how much testing that needs to be done. Sometimes they have to go back and see the cardiologist. Sometimes there are different things that needs to be dealt with. So it does take some time. So the sooner Dave knows he has a donor, the better it is for us to start the workup process. When you get a kidney, there's no need for dialysis, but the person is required to be on anti-rejection medication to keep the kidney healthy for the rest of their lives. Transplant is not a cure. It is one of the treatment options, so it can fail at time. So it is an option, not a cure. Dr. Misu also spoke about peritoneal dialysis, so I'll be very quick. And this is where you're using the lining of the stomach to remove the waste and the fluid. So there are 2 options. There's one, and this is done at home. This is a home therapy where we teach you how to do it. It involves having surgery, putting the tube into the abdominal cavity, the lining of the stomach. Normally, when you put it in, it has to heal for a while, 4 weeks, or sometimes we use it as early as 2 weeks. Some hospitals have where they use it right away. They can do an acute insertion. But normally, the manual exchange is done 4 times per day. And people go 4 times per day? Yes, 4 times a day, because this type of dialysis is actually mimicking or working very similar to how your own kidney works. So we know that we go urinate 3, 4, 5, 6, 7 times per day. So this dialysis is following the same principles, where every time that the water is in the stomach, it sits there for 4 to 6 hours and it's collecting the dirty stuff, the waste, the garbage, extra water. And it's the lining of the stomach is almost like a balloon that it can hold up this water, and it's also like a tea bag in the sense that it can actually filter. It allows things to flow through. And we're using, scientific term like osmosis and diffusion to make this process work. But basically what it is, it's collecting the waste. And it takes around 4 to 6 hours to collect that waste. And then once the water becomes saturated with all the garbage, it's no longer able to hold anymore. So we need to get rid of it. So we drain it out and we put more water in. So every time there's water in the stomach, it allows more waste to gather into that water. So normally, if you're doing it manually, you put your water in the morning, you change it at lunchtime, drain it out, and put more water in again. That water stays until supper, drain it out, put more water in, and before you go to bed, you drain it out and you put more water in. Now, the water that comes out, if you were to test that water, it would be just like your urine. It is urine that we're getting rid of. And we can also use this process, not just to remove the waste, but if the person like Dave has swelling, we can also remove the excess swelling through this method. This dialysis can also be done at night using a cycler. That's it on the bottom of my page here, the cycler. And you would be connected to the machine for the whole night while you're sleeping, usually around 6 to 8 hours. So you want to do it while you're sleeping. And it's doing exactly what I just described, putting in the water, draining it out, but the machine is doing it for you. So the machine is automated and it's gonna fill the stomach cavity with the water. It's programmed how long to leave it in for. It knows when to drain it out and when to put the next bag of solution into the stomach. And it does it throughout the night as you sleep. Now, this is a catheter, what the peritoneal dialysis catheter looks like. It can be inserted locally or under general anesthetic. In our center, we need to do it and it heals for 4 weeks. Now, some centers do it and use it right away. Some centers insert it up to a year in advance, but the tunnel is under the skin, so you can see the outline of it, but it's underneath the skin. And so when this person needs dialysis, they can quickly retrieve it and start the dialysis process within days. So different centers have different techniques. So there's 3, this is just showing you there's a fill where the water drains in. And I must tell you that when the water drains in, you disconnect. So you're not sitting there for the whole time. You can actually move around. So once the water fills into the stomach, you disconnect from the bag and put the catheter away. And you can move around. You can go to church. You can go out with friends for lunch. You can go to dinner, hang out with the boys. 4 hours later, you need to drain it out and get rid of the waste and start the process over again. So this mimics the kidney. And it's good for many reasons in that it keeps you healthy. It's very gentle on your system, and it can be done just about anywhere. So people who likes to travel, for example, this is an excellent method of treatment for them because you can go away and have your dialysis, taking your supplies with you. Now, hemodialysis is what we call blood dialysis. This is the second option. And for this one, it's done by removing the blood from your body, putting it through a filter. And this here is what's doing all the work. This is a filter in the middle. These two on the side, the catheter is access that we put into the neck, actually into the subclavian or jugular vein, or the large vein that leads into the heart. And that's how we're going to get the blood out. Or we can do something more permanent in the arm and put needles in, called a fistula or a graft, and we put the needles in. Whichever way, we need to get the blood out of your body so it can go through this system and go through the filter. Now, every time the blood goes through the filter, a little bit of the waste is removed. So this treatment is done 3 times per week, as Dr. Nathu said, Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. And the duration is about 3.5 to 4 hours. So this picture is just showing you a more, a look, oops, I'm not sure why it's doing that. It's just showing you the access. So the one in the middle called fistula is your own vein that's connected. And we really need to look at these options early because it takes about 2-3 months for this access to be developed enough for us to be able to use it. And the graft we seldomly use, but we do use it for people who have small veins or they just cannot maintain a fistula. And the catheter is probably our least favorite access to use. Some patients' favorite access to use because it's not painful, but there are reasons why we prefer not to use it. A sign of infection, just because of where it's located. So a fistula and a graft are your more optimal access that we would recommend for dialysis. So every time the patient comes, the nurse has to insert 2 needles. One to take the blood out and a second one to return it to the body in the graft and in the fistula. And at the end of the dialysis, the needles come out. You put pressure on to stop the bleeding, just like you would if you had your blood test drawn. They go home, they can do whatever they want with their arm basically and move on with their day. So Dave can actually go back to work after his dialysis if needs be. So this is just showing you a person on dialysis. It can be done at the hospital or it can be done at home. Dialysis is covered by your OHIP, so whether you're doing it at home or in the hospital, it's paid for. We teach you to do it in the home, and all of the supplies that you need is covered by your OHIP. So this is just showing the person hooked up. He is hooked up via his arm, but again, he could have had a line here. It's going through the filter. Once it's gone through the filter, you can't see it, but there's a drain at the back that's getting away, that's draining away all the impurities. And his own blood goes back to his body. And this is done 3 times per week and up to 4 hours each time. Now, Dr. McLew also spoke about what we call it conservative management, medical management. And this is where the patient decides that they do not want dialysis. We also call it palliative care or comfort care. And basically what it is that the healthcare team continues to care for you, making sure that your kidneys are functioning as much as possible, optimal. But you're not looking at dialysis, you're not looking at transplant. Your focus of care is quality of life and symptom control. So we're making sure that we treat your symptoms. We want to make sure that you have everything in place, that you have discussed your advanced care directive and live in real power of attorney document and so forth with your family. We provide support for your family and yourself. And we're tailoring the treatment according to your wishes. Now, I must say, and I'm sure Dr. Nathu sees this as well, there are patients who have opted for conservative management, medical management. And when they're starting to feel sick or unwell, the patient or their family decide that they want dialysis. And that's okay. That's totally up to you. You can change your mind. The only word of caution would be that you really want to do it sooner than later, because if you wait until you're really, really ill with all the symptoms, experiencing all the symptoms, then it's going to take you a longer time to feel better. So if it's something that you're thinking about. So when I hear my patient tells me that they want to do conservative management, the first thing I always say, okay, so what I hear you saying, Dave, is if you came to the emergency and Dr. Nathu said to you that, Dave, if you don't start dialysis now, you're going to die. You're going to just eventually you'll die in the next couple of weeks or so. Is that what you want? Oh, no, that's not what I want at all. I just don't want to do anything right now. And so that's not a true conservative management or medical management. It's just someone who's not ready to make the decision around dialysis. And so we work with them to try and get them at that state of readiness. So my takeaway from this would be that there are 5 stages, and it's determined by your blood test and your degree of kidney function. While it's progressive, not everyone end up developing chronic kidney failure. Symptoms of early stage are mild and can be easily overlooked, and that's why it's important that you have regular checkup. And if you have diabetes or high blood pressure, which are the 2 leading causes, you should be going to your primary physician, and you should be having these blood tests done. And yes, you should be asking to have your kidneys checked out through a urine test as well as blood tests. Early diagnosis and management of coexisting conditions such as your diabetes or your high blood pressure can slow the progression of or prevent progression of kidney disease. If you smoke, you want to stop. You want to have a healthy diet. You want to restrict your salt and sugar intake. You want to get exercise 30 minutes or up to 150 a week. Decrease your alcohol intake. Lose weight if you're heavy. Take your medication as prescribed. Avoid over-the-counter medication as much as possible. You want to get screened for your kidney with your annual checkup, especially if you have diabetes, if you have high blood pressure, if you're over 60, if you belong to certain ethnic groups. There are certain groups that are more prone, as Dr. Nathu said, people of African Caribbean descent, people of South and East Asia, Aboriginal, we are more prone to kidney diseases. If you have a family history of kidney disease, you want to know. And it's not just to know, but you want to ask what these numbers are. You want to know what your blood pressure is. You want to know what your blood sugar is. You want to know what your A1C is. You want to really become what we call self-manage. You want to know about your health. Keep a journal. So every time you go to the doctor, you know what your blood pressure was. You should be checking it at home. I always ask people to invest in a blood pressure cuff to check your blood pressure at home. and know what your levels are. Because oftentimes I'm told, oh, my blood pressure is okay at home, but in my office it's like 170, 180. If you can prove to the doctor that you're getting 120, 130 at home, they're not going to adjust your medication, because there are some people who have white coat syndrome. So that is why it's important that you do take your blood pressure at home and know what is happening in your body. Stay informed about your health. Thank you.
Thank you, Paulette. That was an excellent presentation. It followed Dr. Natu's, and it gave us some real world examples of kidney disease and the treatment. One of the things I should point out is that the message of the Walnut Foundation to our men is to know your numbers. We preach that all the time. You know, what's your blood pressure, what's your PSA levels, etc. So this is really excellent confirmation that know your numbers really do help. Now, there are a number of questions in the chat. I'm going to read them, and then you can address them.
Sure.
So what is the success rate of the liver donor kidney transplant?
Okay, so I'm not sure if Dr. Nathu is still there, but it's really hard to see, and I knew this was going to come up. So when you look at any research, it will, even when you go to St. Mike's, they're going to tell you about 5 years half-life. That sounds really low, but remember, everyone is individual. And I've seen patients in my career that has had a kidney transplant for 25 years. And in my research for this, it also showed that someone can have it as long as 60 years. So I always say, you know, try not to get too hung up on the numbers. Because everyone is different, it's individual. It could be, as I've seen patients who have had a kidney transplant and it lasted hours or days, but it is successful. You're looking at least a good 5 years, 10 years. And the way to look at it is, even if it sounds like a short time, you're still off dialysis and you're still able to live a normal life, doing everything that you would, go on vacation and not have to worry about dialysis.
Yeah. So the next one is, although considered less healthy, are white rice and white bread recommended over brown rice and whole grain, which is high in potassium, for those with kidney disease? Or are there other great alternatives for them?
So I'm going to leave that question for our dietitian who's going to be speaking after me, because this is more her expertise area.
Yeah, not a problem. So in your presentation, you made a comment that Dave, in your example, was not eligible for dialysis. At what stage would he be going on dialysis?
So normally at his kidney function that I presented was 19%. So he's still at stage 4. Stage 5, which is when it's working at less than 15%, is when dialysis is normally needed. You know, it's more when it's more the preparation stage, knowing that, okay, we're doing everything, we're managing it as much as possible, lifestyle changes, medication, but what if things continue to deteriorate? Which dialysis would I want to do? So Dave at 19% is not ready for dialysis, but he needs to start preparing, knowing, and I call it what if. What if my kidneys continue to deteriorate? Which one of these options would I want to do? So if you were to ask, once the patient is prepared, like say they have a fistula in place, they have a graft in place, or they have someone who's giving them a kidney. In our unit, we have patients that can go as under 10% without needing dialysis because they're already prepared. So now we're making sure that they're symptom free. So as long as they're living and they're not having the overt symptoms like nausea, vomiting, swelling, shortness of breath, heart failure because of the water that's building up, the doctor just continues to watch. So I would say by the time they're 7% or so, they're ready for dialysis. But again, if you're doing peritoneal dialysis, it might be a little bit earlier because we want to make sure that you still have some residual function. getting ready and having the access in place is the important thing. But until you're less than 15 or around 10%, you can often survive without dialysis.
So at the lower stages, lifestyle changes is best to get your kidneys working properly.
I'm sorry, can you repeat that?
So at the lower stages of your kidney disease, lifestyle changes is the best way to deal with it.
Exactly. Like you're never, like the treatment is going to be the same regardless. Like you, from the time you hear you have kidney disease, lifestyle changes kicks right in. And that continues, even when you're on dialysis, you really have to continue with lifestyle changes because, you know, diabetes or high blood pressure, we said, are the two leading causes. But it's not just the kidneys that these organs affect. They affect your heart, they affect your eyes, they affect other organs. So even though you're on dialysis and the kidneys may not be working, it doesn't mean that, okay, I'm going to eat everything inside, I'm going to not worry about my blood pressure.
See?
You still have to.
I'm telling you, I am just
Sorry,
hold on. I'm losing my mind.
Hold
Bye.
Sorry, you still have to because you have other
person.
organs that you have to worry about.
Okay. Okay. So let me just, I just had to mute that person. Are there any tests performed on kidneys donated by dead people to make sure they're healthy and fit for transplant?
Yeah, so definitely, you know, they're gonna make sure that their organs are procured properly. So if the person have any HIVs or hepatitis or anything that's chronic, tuberculosis and so forth, then those organs would not be suitable for transplant. Yeah. And that's what I said to patients, because some patients do go away to, you know, Europe or Asia to get a kidney. And I always say you need to be very careful. Because when someone is selling a kidney or giving a kidney, you don't know what they have. They could have a number of issues and you now inherit those issues. So if they have, for example, if they have hepatitis or if they have HIV, once that kidney is implanted into you and the blood starts to flow, you now have whatever he has. So yeah, there are things that there are tests that they do here to make sure that the organ is free and free of such chronic disease, of such chronic condition or contagious conditions.
Of the two methods of dialysis other than convenience, is one better than the other or more recommended by the treating professional? So
oftentimes we recommend peritoneal dialysis more because it's more convenient, it's more gentle on your body. Now, one of the things that patients often can complain about or experience when they're doing dialysis, especially the hemodialysis 3 times per week, is they get really, really fatigued. So I know fatigue is one of the reasons why they start dialysis, but imagine coming for dialysis, your blood is coming out, it's going through this filter. The faster we're able to get the blood through, the more time the blood goes through, and the more waste you gets removed. So I always say it's like driving from Scarborough Town Center to the hospital where I work. If you go at 30 kilometers an hour, you're gonna get there slow. If you go at 90, you're gonna get there really fast, but it's more work on your engine. So patients, the faster the blood pump is to get the kidney, to get the blood filter, they're gonna get a good cleaning, but they're gonna go home feeling really tired, and they have a name for it, washed out. They feel like, just blah. And so they rest up, they feel better the next day, but it's just to repeat the same process the following day, and it's a continual process. Peritoneal dialysis, because it's almost mimicking how your kidney works, like you're going to pee, you don't get that washed out feeling. You don't get that tiredness. It's a more gentle process. So if I have a patient that comes in and they have, one of the things that they do is that they retain water. And so sometimes they don't pee as much anymore. So everything that they drink stays in their body. So if they have 2 liters or 2 liters to remove, if they're only here for 4 hours, I'm going to remove that in that 4 hours. And so sometimes they can drop their blood pressure, they can get cramps, they can feel unwell. If the patient is doing peritoneal dialysis at home, they have 4 sessions to remove that same 2 liters. So they can remove a little bit in the morning, a little bit more at noontime, a little bit more in the afternoon. And so they can spread it out throughout the day. And that prevents their blood pressure from dropping. It prevents them from feeling unwell and just having the cramps and all the other washed out feeling that may go along with the peritoneal dialysis, with the hemodialysis rather.
Okay.
So yes, it's a more gentler treatment. Patients feel better, their diet is better, they eat better. It's a little bit less restrictive too in how they can eat because they're cleaning their blood more often. We never were meant to pee every other day or to clean our blood every other day. We clean it every day when we go to the washroom, how many times per day. Hemodialysis is great, it's a good treatment, but it only cleans the blood every other day.
Okay. How long can one be on dialysis for?
So if you read any, if you were to pull it up on Google or any site, it'd probably tell you about 5 years or so. But again, it depends on your other comorbidities. So, you know, if you have a bad heart or, you know, other comorbidities that's affecting, then that will have more of an impact. I always tell patients that they die not from dialysis, but from their complications or the other comorbidities that they have that cause them to be on dialysis in the first place. So I've seen patients on dialysis for over 30 years, and I've seen patients on dialysis for 6 months or a couple of weeks. So average, they say, is about 5 years, but that is just a statistic. It could be much longer.
Okay. So this other person says, excellent presentation. In your opinion, which type of dialysis is more effective for children with ESRD?
So I don't work with children, Sick Kids Hospital. We don't get them until they're 18, but they do have both. They have peritoneal dialysis for kids as well as hemodialysis, and they do have it at home as well. I would think like anything that you're able to do for my group of patients at home yourself would be a better treatment. So I can't really specifically speak to kids because I don't work with children.
Right. So someone says, will a recording of this presentation be available? Yes, we should have it by mid next week. Okay, because normally what we do is break the presentation up by speaker, so you can go directly and listen to that speaker. Is there an age limit from a donor?
From a donor?
Yeah.
Or
from a donor.
Okay. So you want to think, you know, if you're 30 years old, you wouldn't want to get a kidney from somebody who is 60 because your kidney ages with you as you age. I think the youngest donor, I would say they probably would in their 60s maybe, because after that, you're starting to have your own health issues as well. I've seen mother give to daughter and son, but usually they're in their 60s. Is there a donor? Is there an age that they stop transplanting? I've seen people get transplanted as old as in their 70s as well. So as long as you're healthy, we don't set the criteria. If I have a patient who wants to go on a kidney, you know, has a donor and wants to be worked up, I will start it and I will send it to St. Michael's, and they will be the one who makes the decision whether or not that person is suitable to go through transplant or not. We do, you know, if you're 80, I would say, well, it's probably the surgery itself is very taxing. You're looking at a 5-hour surgery for transplant. So it's gonna look at your overall wellness.
Okay, thank you. What is the infection rate of doing PD at home, dialysis at home?
So there's actually our governing body, Ontario Renal Network, that set a benchmark as to, percent of infection. It's called peritonitis, and it's very low, really. I think it's 1 point something. Infection can be avoided. There are certain steps that you have to follow when you're doing your dialysis. Most hospitals fall below that percentage of 1.2, and no, ours at Scarborough is like 0.8 or so. Infection could be minor. It could be, you get infected and you take some antibiotic and it clears up. Doesn't mean you have to stop peritoneal dialysis. If you were to compare that to the hemodialysis, there is a higher risk for infection doing peritoneal dialysis than doing hemodialysis. Just because with peritoneal dialysis, if you remember, I said that you're doing the exchanges, you're opening the catheter 4 times, so that increases your chance of infection. However, if you take the added precaution and make sure you follow the steps, it's highly likely that you will not have an infection.
Okay, great. So this comes to the end of our questions, Paulette. This has really been an excellent presentation.